call or just one. May or may not have had this overview during the recruitment phase, but it's really important that we have all team members on the same page as we move toward launching and enrolling your first patients in early October. So we'll provide a COMPASS study overview, and then we'll move into the components that as a control site you all will be conducting, in that case ascertainment and enrollment. And we'll also talk a little bit about the web-based data entry, quality control, and then there's some administrative points that we want to make sure that we summarize for you. And then we'll talk about next steps going forward, and there'll be plenty of time as we move through each of these areas. If you have a burning question, don't hesitate to stop us and ask us as we move along the way. And we'll also have plenty of time at the end for questions and discussion. Next slide, please. And so, again, we are welcoming you on behalf of the COMPASS study team. I'm Sylvia Coleman. I'm the Director of Implementation for the study, and I'm just going to call a little bit of a roll here, and then I'll have my teammates introduce themselves but as they speak. But we do have our principal investigator of our team, Dr. Pamela Duncan, or Pam Duncan, is with us this afternoon. We have both of our project managers. We have Misha Sassine as well as Sarah Jones, who's our project manager on the UNC team. And Laurie's already introduced herself to you, Laurie Medham. And Laurie will be your primary contact as a control site, so you'll be having lots of communication with Laurie in the coming weeks and months. And they can tell you a little bit more about themselves as they go about making their presentations, but I wanted to just acknowledge those of you from the site who are on the phone. Dr. McKinney, are you on from New Hanover? We see your name up there, but we couldn't hear you previously. Are you with us?
Yes, I'm on the phone.
Awesome. Thank you. It's good to hear your voice again. And Davita from CHS Blue Ridge, you're able to hear us okay, Davita? I see your name up there, so hopefully you can.
Hey, I'm here.
Okay.
I think somebody unmuted me.
Okay, all right, great. Good to hear your voice again, too. Haven't seen either of you in a little while, but it's great to hear your voices. And Tina from Novant, I see your name up here, too. Are you able to hear us? Can you acknowledge that you can hear us? Hopefully, Tina, you can hear us. And Denise, I see that you have joined us. Denise, are you able to hear us okay and speak?
I can, and I also have Teresa Shelton and Natalie Hall with me.
Okay, perfect. Hey, Teresa. Hey, Natalie. It's so good to have you all joining us as well. And I'm going to just ask, is there anyone whose name I did not call that has joined us? Well, I think we have everyone that we were planning on participating this afternoon in attendance now. So I'm going to turn over to Laurie to move us forward. And again, we do welcome you. We are so excited to be at this point with starting to implement and start launching in early October. And I look forward to working with each and every one of you in the coming weeks and months. Laurie?
Hi there. I'm so glad we are able to have this time to review our case ascertainment and implementation phase for Wave 2. I personally am looking forward to working with each of you. I've had the opportunity to have some email exchanges, but it's great to hear your voice, and just after launch you'll be seeing me and the rest of our team in person at our site visits. Speaking of which, I just want to give you a brief time frame. So we are, of course, focusing on the case ascertainment webinar today. And then we'll have our launch October 3rd and come out to see each of you starting October 13th. You've probably been receiving lots of emails from Ann about, okay, let's set this up so we can come and visit and spend time. And the focus of that site visit will be to learn any challenges and any successes, well, all of the successes that you're having. We anticipate a lot based on Wave 1 and all of the great people that are involved in this study. And then we will be having bi-monthly calls. So now now that you have a general overview of the schedule for Wave 2 usual care, I wanted to turn the mic over to Dr. Pam Duncan, who will do an overview of the COMPASS study for those of you who may be very new to it. Thank you.
Thanks a lot. Thanks, Laurie. Thanks, Sylvia. And let me just say that this has been an incredible team effort among the team here, but also all of the team members out in the field who've made it possible to be at this point in this very important study. I am the PI, and Dr. Cheryl Bushnell, who I'm speaking on her behalf today because she's seeing patients, is the co-PI, and she's the professor of neurology and director of the Wake Forest Baptist Comprehensive Stroke Center, and really has, with our team here, set sort of the standards and purpose for this trial. And then Dr. Wayne Roseman, who many of you know through the North Carolina, formerly the North Carolina Stroke Care Collaborative, who's an epidemiologist, and Sarah Jones, who we will introduce here in a moment, really they lead all of the methodology in terms of case ascertainment and managing data and data analysis. So we're very fortunate that this is a cross-cutting study across Wake Forest and UNC primarily, but we also have leaders from Wilmington, ECU, and Duke that belong to our team. But I'd like to pause for a moment, and I know that two of our project managers, because on a day-to-day basis, they run the study and many of you have been in contact. Is Misha Sassine on the call? Not sure she is, but she's the project manager.
I'm here.
Okay, Misha, can you just speak for a moment and tell everybody about what you do in your scope?
Yes. Can you all hear me?
Yes. Yes.
Oh, okay, great. Hi, everyone. I'm Misha Sassine. I'm the project manager for the COMPASS study here at Wake Forest Baptist Medical Center. I will be presenting a little bit later on the administrative section of this webinar. But my primary role, I've actually spoken and emailed with several of you, has been with management of the IRB and also the overall operations of the study.
Thank you, Misha. And the second person that you'll also be hearing from today is Sarah Jones, who is a project manager and really a strong methodologist from the UNC site. And Sarah, do you want to introduce yourself and speak for a second?
Sure. Good afternoon, everyone. As Pam said, my name is Sarah, and I am working primarily on the data capture parts of the study, quality measure reporting, and some of the analytics. And so, welcome, everyone.
So actually, they are just incredible leaders here with both Laurie and Sylvia, and ensure that we make this happen every day. So next slide, please. Okay, so I'm going to go through some of this relatively quickly, but and these are points that we've made in the past, but we have huge gaps in stroke study, in stroke care. And we know that currently we have re-engineered care for acute, hyperacute management, but then the patients may be seen in your respective health facilities, and there's a big gap in terms of how we set the standards for care, where patients may go, and how we reintegrate them with community-based resources. And it's very important to note right now that 42% of stroke patients, once they leave the hospital, are not referred to any post-acute care management. And if you're under the age of 65, 65% of the patients are discharged without services. And we're in this arena of not having performance indicators for post-discharge care, even though we all have performance measures for inpatient care. Now, this gap is a major contributor to challenges in health care, and we know that there are many things that happen to patients after discharge, that they have new disability, obviously affiliated with the stroke, that may not have been comprehensively detected or assessed during acute care hospitalization. They're at risk for mobility problems, falls and fractures, cognitive issues that impact stroke care, and obviously we all know the stroke complications of pneumonia, DVT, infections, and certainly depression limits their ability to recover. Next slide, please. So not only do the patients have major trouble, but the caregivers have trouble too after discharge. And the caregivers, and we all on the front lines realize this, people are being discharged home sicker and sicker with multiple comorbidities and challenges in getting resources connected all the way from the primary care to their home health visits. And this creates a tremendous amount of stress for caregivers because they're often the ones who help the patient manage and navigate the care, so it contributes to poor mental health for them. Then they become the primary contact and the primary navigator of the care, so they have less social contact and activity, and they are at increased risk for depression. The burden on caregivers, as I said, is escalating and certainly a keen concern for all of us. So we have developed this study both with insights from all of you as we've gone around and spoke to you and recruited sites, but also as we spoke to patients and caregivers. And this is what stroke survivors and caregivers said. They wanted reassurance that they're going to get better. They want to know, how do I keep from having another stroke? They want support from both their peers and health professionals that understand the trajectory recovery and what they might expect after discharge. And they want access to that information, and they want consistent messaging on the information. And that each provider who works with the patient doesn't create their own independent plan of care, but there are coordinated efforts across the stroke experts as well as primary care and the post-acute services. Next slide, please. So we have in post-acute follow-up many key players, and we have therapists, and we have the acute stroke neurology team or a hospital-based team. We have primary care, home health, and community resources. But in the middle of this is the patient and caregiver, and so they're requesting that we be able to coordinate and manage the messaging and the care across these multiple providers. Next slide, please. So what we want to do is try to improve the care of stroke patients regardless of setting and provider. So it doesn't matter if you are a small hospital in eastern North Carolina or a large hospital in eastern North Carolina or a big academic medical center. When you go to look at performance measures for acute care, you have the same standards of care. So our challenge is that in post-acute care, because of some of the diversity and access to services, you know, how can we homogenize some of the indicators for care regardless of the setting and the providers? Now, in all of our acute stroke management and in our rehab, we're really talking about stroke recovery, prevention, and comprehensive coordinated services. But how do we compare this model to usual care is not exactly an easy task. Next slide, please. So we wanted to work with partners, and honestly, many of you may be providing these services. And as we get many mandates from CMS to increase transitional care management, chronic care management, and now MACRA, you know, are these recommendations, is there uptake from the patients? Is there uptake from the providers? And how realistic is visit to provide these services. So what we want to do in this study is to say, well, in the sites that are in the intervention phase in phase 1, which you will be in phase 2, let us put forth a more structured staffing and process approach. So what we're saying is that there are existing billing codes, even under fee-for-service right now, called Transitional Care Management and Chronic Care Management, where if they're a Medicare patient, they can be billed for these services, or even if they're not a Medicare patient, many providers will pay for follow-up post-acute visits. So we're trying to look at existing financial reimbursements for most of our patients to get these services. And then we want to incorporate early supported discharge with very trained APPs and RNs in terms of establishing a staffing model as well as a provision of certain care. And then in our preliminary work at Wake Forest Baptist Medical Center, where we honestly don't get the return of all of our patients, but for those who do return, we showed that we could reduce readmissions. Next slide, please. And this paper was published earlier this year, and we looked at just nurse practitioner, registered nurse transitional stroke program management, and demonstrated that we could reduce readmissions, that patients readmitted within 30 days were less likely to show for the transitional care visits, and there was an overall 48% reduction in 30-day readmissions. I might say, however, and this is a chart of all of this data, is that what we also found is if the patient just got the follow-up call, that was not sufficient, right? So there was no difference between the outcomes between 30-day readmission and no readmission if you only got a follow-up call. But the transitional care visit was highly significant in terms of outcome. And so we can see that transitional care management associated with a 48% reduction in 30-day readmission. Now, this, if you read the article, and I want to keep this in mind as we talk to you as a usual care site or as we talk to intervention sites, it was a work in progress in terms of trying to slowly escalate our ability to capture more and more patients into this service. Next slide, please. So what is a comprehensive post-acute stroke study about? First of all, let me just say this is an incredible opportunity across the state of North Carolina that we will have 40 hospitals by this week. Randomization, it's closing out. And we have already randomized, I think, about 26 hospitals. I lose track there. Exactly how many hospitals have we randomized as of Friday? We've done 20 in this, and then how many were randomized on Friday?
We randomized an additional 6 on Friday.
Yeah, so we've got 26 hospitals randomized, and we will soon, in the next a week, have the 14 randomized, additional randomizations. So we have made significant progress to get hospitals engaged. And hospitals have been very interested and engaged. I know that you're the usual care site, and we'll come back to that, and the team will talk to you about that, is that it's important for us to see, well, number one, what's happening in usual care as you begin to think about services, but also what happens to your 90-day outcomes of patients. But we're going to do a comparative effectiveness study of a very structured, progressive model of staffing and systematic assessment of the patient using e-care plans to say, does this very comprehensive post-acute stroke care really improve functional status at 90 days post-stroke? We certainly will be looking at caregiver strain as well, and we'll look at all-cause readmissions at 30 and 90 days, and mortality, healthcare utilization, and the use of TCM billing. And both the the usual care site and the intervention sites will be assessed in the same way. So we have randomized, and again, as I said, we'll have randomization completed within the week. And we randomized hospitals to either COMPASS intervention or usual care. And in the usual care arm, which you are, you'll actually just ascertain the cases and advise the patients about the study. And certainly one of the things at bedside, and they'll go over this with you, is about reinforcing blood pressure. And then you care for them as usual, and then we'll look at the 90-day outcomes. But after that first year, we will then cross you over to intervention. And while we're looking at you doing the intervention site, we'll expect the first site who got the intervention to sustain the COMPASS intervention. So it's randomization by hospitals. And again, the team will clarify this as they speak. Now, what we will do for the intervention sites only, we will provide them feedback about the percentage of their patients that will call within 2 days, the percentage of patients that got back to see a nurse practitioner and PA within 7 to 14 days, and then the percentage of eligible patients that were referred to rehabilitation services. Next slide, please. So what's really important in this trial is that we have a huge diversity in hospital sites across North Carolina, from east to west, and diversity in volume of patients they see, or as to whether they are a primary stroke center or not. And we're basically asking real-world providers to implement the intervention or to provide the care that you usually do under the current reimbursement models, and that we collect meaningful patient outcomes. And the meaningful patient outcome to them is not hospital 30-day readmissions. It is to us as health systems, but to the patient is, did I get better? Did I improve my functional status? And that is our primary outcome. Next slide, please. So in summary, we need to test whether the COMPASS model truly improves functional outcomes and reduces caregiver strain for stroke patients in North Carolina. And we really look forward to working with each of you. And if you want to tee up the next slide, but then I'd like to add a few additional points before we turn it back over to the team. This project is extremely timely. As you well know, there are many, many efforts out there for CMS to hold health systems responsible for 90-day outcomes of their patients, especially as it relates to utilization and cost. And they also will impose functional status as an outcome. They have done bundled payments now, and they are expanding that from joint replacements to total hip, to fractures, myocardial infarction, and cabbage. We all thought stroke was going to be the next one. It wasn't, but we know that it's coming. So the infrastructure that we're testing here, both for the intervention and the usual care site, we do believe that we'll be in a position at the end of 2017 to begin to be able to disseminate modules and learning lessons so that health systems will be ready for bundled payment when it arrives for stroke. We also want to be partners with you as we go forward. We're not going to be intervening specifically with you, but Sarah will probably address this. We want to know over the course of time, over the course of where you are right now and where you are at the end of this first phase, did you change the way you delivered care? But when we close the study out for the first phase, we will also give you your 90-day outcomes. And we're collecting that through the University of North Carolina. So you will be able to see for your overall cohort of patients what your 90-day outcomes. And obviously when we close out the first phase, we can also tell you what the comparisons are with the usual care and intervention. This is an important study because CMS is mandating a lot of us in very complex patients, and we really need to see if patients buy into this model of care. We need to see how feasible it is to get patients back. We need to look at the resources required to do this, as well as ultimately what the outcomes are, and that we should be in a position to help all health systems understand how to manage bundle payment when it knocks on our door, or certainly how we can begin to start collecting now transitional care codes or chronic care management. So I'm going to stop for a minute, and I may have gone over my limit, so please, before I'm going to have to leave the call, but if any of you have any questions for me, or just to go forward, I'll pause for a minute if any of you have any questions. No questions? I just want to applaud. We are rolling out in waves. You're part of wave 2. We've had wave 1 in the field now for about 4 weeks. And because of this team and incredible support, the other thing is we are having great success in case ascertainment across the control and the intervention site. Great success. And really no major complaints of significant burden. But I'll let the team who does this on a day-to-day basis. So again, thank you so much to each site, and the year will go fast, and then we'll be turning around to then orient you to intervention. Thanks a lot. Thanks, Laurie. I'm going to turn it back over to you.
Thanks so much, Pam. Okay, now what we're going to do is we heard that wonderful overview of the COMPASS study. Now we're going to go into the various details. First of all, on my favorite subject, we're going to look at data. We want to know all the excellent work that each of you do, treating patients and capturing information in the patient reports and so forth. How are we doing in the process and in the outcomes? So we're going to focus on case ascertainment and enrollment for the next few slides. Can everybody hear me? Okay, I'm going to make an assumption that that's a yes, because I'm on speakerphone.
I can hear you.
Alrighty. Now, this diagram shows all of the points that patient data is collected for the COMPASS study, which includes intervention and usual care. But the focus of this afternoon's talk is going to be on the patient enrollment and data capture. Now, there are a few steps in case ascertainment enrollment. First step is to identify presumptive stroke and TIA cases, and to conduct your eligibility screening, visit the patients before discharge and describe the study, as Dr. Duncan mentioned earlier. Complete the enrollment form, complete the acute stroke care stroke registry data. Many of you, and I think most of you, collect Get With Guideline data, and some of you also collect the Stroke Care Collaborative data for acute care. So for step 1, we're going to identify all stroke and TIA cases treated at your hospital. So this is a protocol that we developed, and it is based on key informant interviews. We called various stroke care coordinators that participated in the Stroke Care Collaborative when planning this protocol, and they provided information on their protocol for identifying stroke cases. So first of all, you want to review your admissions daily, and you can query your electronic medical records in various sections of the hospital, such as stroke service, ED and OBS units, admission, neurology consults. And then that will provide a large list, but you want to narrow that down to make sure that they are no duplicate cases and that they are all presumptive strokes. So you review those records using keywords, working diagnosis, chief complaint, and imaging. So I'm picking up this here. Okay. So now looking at greater detail, sorry, having a little technical difficulty. Okay. So a few notes. You want to review the weekend admissions on the following Monday. We make the assumption that people don't work 24/7, and that many people find that they accomplish the case ascertainment that for the patients that are discharged on the weekends on Mondays. Then you screen your inpatient strokes, and inpatient strokes are those patients who've experienced a stroke or TIA when they were admitted for another reason. And then you also want to be sure and include OBS patients and those who are not admitted that are discharged from the ED. So for step 2, eligibility screening, that includes all presumptive stroke and TIA cases. You'll notice that I mention that TIA a lot because there are some hospitals I know that had not been collecting TIA cases. So the criteria for eligibility include their age. They need to be an adult, 18 and over, English or Spanish speakers. We do have the brochures translated into Spanish, so they can be included in the study. And then the stroke or TIA diagnosis, but that does exclude subdural and aneurysmal hemorrhage. And this study is focused on stroke patients that are discharged to home. And then you'll want to enter that data into the web-based application, and we have found that it takes approximately 1 or 2 minutes for the actual entering the case in the eligibility form. And that screening is an ongoing process. There may be patients that you have, they're on your list of they're going to be discharged home, and you find on the day of discharge it turns out that they are actually discharged to a skilled nursing facility, in which case you could go in and just change their eligibility screening so they are no longer part of the study. Now this is an algorithm for your future reference for case ascertainment. I'm just going to go through that. So for the initial patient contact, you'll want to meet with eligible patients and their caregivers before discharge, and it's a great opportunity to distribute the COMPASS brochure and the blood pressure handout. And you want to encourage the patient to track blood pressure monitoring and hypertension. I know for those sites who are very familiar with the performance measures for acute stroke care, that stroke education is one of the performance measures. So this fits along with that to provide this handout, this blood pressure log, so that people will be collecting their blood pressure on a daily basis, and then they can share that with their primary care physician. And then you also want to introduce the study and explain that they'll be called in 3 months and invited to participate in a phone survey. And then you can answer any questions. So a little piece of homework for you, and I think that you've probably heard from Ann Furstenberg by this, and many of you have already responded, and thanks for that. We want to be able to customize your brochure so that when you go in and meet with the patient, it'll have your hospital logo on it, and it'll have specific information that you want to include in that brochure. This is a copy of the blood pressure handout that I mentioned to you earlier. And then you want to complete the patient enrollment form. That includes contact information for the patient, and then caregiver information, demographics, medical history, in-hospital data such as NIH stroke scale, and that takes about 8 to 12 minutes to complete. So there are a few tips. When you go in to see the patient, you can print the paper version of the enrollment form. What people have found is they will collect information that's in the patient's electronic medical record about what their phone number is, and they go in and see the patient and to verify that and find out, no, the phone number is no longer current. So you, by all means, use a paper version, but we just ask that that be transferred into the web-based version at a later point. And then the in-hospital patient data from the electronic medical record can be entered on the enrollment form after the patient visit, as I mentioned. And we've heard some folks say that when they mention the word caregiver, the patient will say, oh, I don't need a caregiver. And what has been successful at many sites working with patients they'll say anyone who helps them with their daily tasks when they get home, such as taking them to the doctor's visits. So the last step is to complete the either the stroke care card or the patient management tool, and we will need to obtain some additional in-hospital and treatment data, and we will link that with the Stroke Care Collaborative or the Get With It guidelines. So we ask that you complete your stroke care card or PMT. That's usually done by 4 weeks of patient discharged based on your standard practice. It may be that you have one patient that does case ascertainment for all stroke cases, and so you'll want to work with that patient to make sure that you have a spreadsheet with the COMPASS ID number and the patient's electronic medical record number, so that you want to avoid any possible duplications there. Okay, and then what happens next? So after discharge, your protocols will remain unchanged from your usual care, and the COMPASS study team will send informational letters to patients, and we'll call them 90 days for a survey, and then the outcomes are collected as part of these phone and mailed surveys. So that is a general overview of the case ascertainment. As I mentioned, there's 3 steps. Now let's look at what how you would see it on the web-based application. So you hopefully will become familiar with our homepage here, which is you want to set up an account, and many people want to immediately put in their email and password, but I will recommend that you go to Request Account here and click on that, and you will receive an email that's computer generated, so you may need to check your spam folder to set up an account. And I will also be sending you a test case, and it's very important to note that we request that you set up a test account first to run the test case, and then you will have to set up your account for a production site at a separate time, so that we keep the test cases separate from stroke patient cases. So this setting up your profile requires a couple steps. Most of the time it's about 10 minutes, and Sarah and I will be there to approve your account. And please note that in order to obtain an account in the COMPASS application, you will have to have the city training or the alternate COMPASS training, which takes about 10 to 15 minutes. So this is what the dashboard looks like. What I do is I usually orient everyone towards home, and you'll want to click on home, and that is, you can see the patient dashboard, you can create new cases, and you can view and edit cases. And then reports, as Dr. Duncan mentioned, you will be able to access your performance measure reports in the future. And then my profile, that's where you can edit your user profile in case, for example, your email changes. So let's look a little closer at the patient dashboard. You'll notice that under workflow there are different colored buttons. Each of those buttons is a different form, such as eligibility, enrollment, stroke care card, or PMT. And the usual care sites will see just the eligibility, enrollment, and the stroke care card, as I mentioned. And then you want to click on the form of an existing case to open the form to view or edit. And then the colors represent the completion status. Green is that it's complete, and blue is that it is next in line to be completed. And here red is for those that are overdue. And you can filter your cases. Let's say you want to search a case and you want to look for, well, I want to see all of my eligible cases that I've already enrolled. So you will click on filter, click down on the status button and choose eligible, enrollment complete, and click on that, and it will list only those cases that are eligible. Now, in order to enter a new case, you just simply click on the new button highlighted here by the arrow, and then it will pop up, is this a new case? Most of you, the answer to that is yes. For those stroke care collaborative hospitals, if there is someone else who enters that data, again, you'll want to work with them to avoid any duplication so that you have the shared spreadsheet of the Compass ID numbers. So your eligibility form, it's fairly self-explanatory. The top row displays the case IDs, hospital case status and user, and then down on so you go through each of the questions, and then down at the bottom you click on Save and check eligibility. If it's eligible, you get the green banner that says, oh good, you're good to go, and then you can move on into the enrollment form. And then I just want to show you the column at the left under Home. It is the different sections of the enrollment form, and the check mark obviously means that that section is done, and the blue bar is the section you're currently in. And then you want to complete the stroke care card or the performance management tool. Basically, you do it according to your normal protocol, 2 to 4 weeks within discharge. And I mentioned a number of times about the crosswalk and establishing the communication between your data abstractor for acute care and the person that's going to be entering your Compass cases. And then there are a couple ways to access the stroke care card for those of you entering cases into the stroke care collaborative. You can either go through the Compass patient dashboard, and you'll see that arrow there that just click on the SCC, or for those people who have a separate person that's entering acute stroke care data through the collaborative, then they could also just go in through the usual collaborative portal. And then for the collaborative sites, they'll be very familiar with this form. The data that's common between Compass forms and the Stroke Care Collaborative will pre-populate the Stroke Care card, and then it's the same format as the enrollment form with the left-hand menu. Get with the guidelines, it's very straightforward. You just complete the PMT within 4 weeks of discharge. And I do want to make a note that Compass case includes TIAs, OBS patients, and ED-only patients. And for the Get With the Guidelines sites, you just go down here, you see where the blue arrow is, click on PMT, and you simply enter the Get With the Guideline case ID number, and that will be used to link your records. Now, I mentioned a test case. When I set you up for the test site, I will send a test case for you so you can just become familiar with the data app. So far, everyone's found it very straightforward and easy to use. And if you have any questions, please don't hesitate to contact me. And now I'm going to turn it over to Sarah, who's going to talk about data quality.
Okay, so we're going to shift gears a little bit and talk about the data quality and case ascertainment quality. So I just want to frame it a little bit and talk about why it's important to accurately identify all the cases. Missing data can have a lot of implications from a research perspective and from a clinical perspective. So obviously, it means some patients may not be identified. They won't receive the 90-day survey call or any of the follow-up that Compass does with enrolled patients. It can introduce bias into the comparative effectiveness estimate, and Pam talked about that at the very beginning of the webinar. And then it can also lead to inaccurate patient outcomes, which are reported back to you, like readmission rates and so forth. So obviously our goal is to reduce missing cases and inaccurate data. So we did a few things to assure better data quality on the front end to make it easy for you guys to enter data. We have built-in range checks. We have skip cross-question validation, sort of date checking. We have saving rules to minimize missing data. And we're going to do regular monitoring of the data quality. Those reports will be made available to you, and they'll be discussed on the bi-monthly calls that Laurie will be hosting. And we'll also do a retrospective case ascertainment audit, and I'll talk about that procedure on the next slide. But before we, can you go back one slide? I just want to say that, and you hear this a lot from Sylvia and Laurie and everybody on the team, we're here to help you. If you have any difficulty with any of the procedures, just reach out, and we are here to help. Okay, thank you, Laurie. So this is a description of the case ascertainment audit procedure that we'll be doing periodically over the study period. And the purpose is very simple, which is just to compare the COMPASS enrollment list to a hospital discharge list provided by you. And so that comparison is done by our statisticians here. And what we'll ask you to do is simply generate a retrospective list of discharges. This can be done, in Epic with a simple query, and then you'll upload that into the data application that Laurie showed on the report section, and then we'll review that and get back to you and report back the results. Okay, so that was just sort of the big overview of data quality that we wanted to share, and we have tried to make all of our procedures align with your current systems. So with some adaptation to meet our study goals, we have a web-based data entry to facilitate enrollment concurrent with care, and we have put into place systems that promote good case ascertainment and timely follow-up for when you transition into the COMPASS intervention arm. Okay, so any questions about data quality before we move on to some administrative topics? Okay, well, and people are welcome to email after the webinar if something occurs to you. And I'm going to turn it over to Misha now, who's going to talk about IRB and consent and so forth.
Hey everyone, can you all hear me? I think I'm hearing my echo. So
Yes, we can hear you, Misha.
Great. And I'm assuming that either Laurie or Sarah, who has control over the slides, will help me with kind of advancing the slides. Okay. Well, since I don't have control, if somebody could help with that, that would be great. So I introduced myself earlier. I'm one of the project managers on the COMPASS study, and you can go ahead and advance the slide. Today we're going to talk about some learning objectives for the administrative overview. Hey, Sarah or Laurie, do you have control over the slides? Could you advance them? Sarah.
Hey, this is Laurie.
Hey. Do you mind advancing?
Yeah, happy to.
Awesome. And you can go ahead and just like skip through that one. So the COMPASS Central IRB, a lot of sites have opted for the Central IRB and have relied on Wake Forest for oversight of the COMPASS study at their site. A number of you, though, on the call today, New Hanover and Avant have local IRB coverage. So I'll be working with you separately and individually to make sure that your local IRB has the latest documents and that we're adhering to your local IRB needs for review of the study. No, next slide. So a little bit about, this would apply for our central IRB and then also for your local IRBs, is we want to make sure that we're adhering to the study protocol as closely as possible. This is a pragmatic study, so we do anticipate that there will be some slight modifications to make sure that it's incorporating into your site. But overall, we want to stay as close as we can to the study protocol. So that means if there's any needs for modifications for the protocol at your site, we would want to know about that ahead of time and make sure that we have IRB approval for that ahead of time. And I listed some examples there. So that would include, of course, any changes in inclusion and exclusion criteria. We would want to run that by our IRB, of course. And then if you have any major changes in your study personnel, so if you're, there's a change in leadership and the principal investigator needs to be added or removed from the protocol, we would want to let our IRB know that, as well as if you're consistently changing any questions, or if you're going to need some changes to your advertisement for the COMPASS study, or any kind of wording changes on the informed consents, we would definitely want to let our central IRB know that. And then if you have a local IRB approval, then we would want to let them know as well. So next slide. So we're going to also just wanted to remind everyone who's on the call, and you all have had the city training, that to maintain compliance throughout the study as well. So these are pretty obvious examples, but I just wanted to make sure that everyone was aware. We want to avoid falsifying any IRB documents, of course. And then we do not want to conduct any research without IRB approval, which we have IRB approval for all of the sites on the call today, so no problem there. And then, as mentioned earlier, if there's
come to nursing administration on the ground floor.
Oh, hey Tina, I think I'm catching some of your side conversation. I think she's already muted herself. Okay, let's see, where were we? And then, of course, I'm here, and our team is here to help with maintaining the IRB documents. So that's one of the benefits of participating in the central IRB, is we will handle that all here. And then for those of you with local IRB approval, we'll work with you on that as well. As the site PI, I'm seeing some PIs on the call. One of your major responsibilities is overseeing the research at your site. And if you'll go to the next slide, we are not tracking adverse events, which is the last point on this slide. But we do have a data safety monitoring board, and they have asked that as a PI, if there's any questions or concerns at your site, we want to know about that right away. And by right away, just some guidance there is within 24 hours of you hearing of it, or as quickly as you can possibly kind of connect with us on that. So we do not, this is a very low risk study. Both the IRB and also the Data Safety Monitoring Board has looked at our protocols, and they consistently agree that the real risk is with ensuring the security and confidentiality of patient data. So you're well aware of this, but just be careful with, don't share your passwords for logins. If you're printing material that has sensitive information or emailing that, make sure emails are encrypted. And then if you're calling patients, to do that in a private area. Okay, so let's see here. Okay, if you'll go back one slide, Lori. Thank you so much. So the consent design and process, just a reminder here that our consent design and process is that all patients are captured. So your control site, so any eligible patients that are eligible for the study, we are going to capture them, we are going to enroll them into the study. So that is how we have designed this particular study, and this is the pragmatic design that we've worked with our IRB and with your local IRBs on that. So next slide. So the COMPASS study notification, all patients are notified at bedside, as Lori was describing earlier today. So they're all notified before they are discharged from the hospital. When we approach the patient, we notify the patient that your hospital is participating in the study and that your hospital has been randomized to providing usual care. We have a study brochure, and we actually have a packet of information that is created for you, specifically for your site. In that packet of information is the study brochure, which outlines all of this information. So one approach that we recommend is, as you're approaching the patient, you could just pull out that brochure and kind of walk through that brochure with them. But that brochure will say that it'll have your hospital logo on it, and it will talk about the type of post-acute care that they should expect to receive. And that brochure will also say that we are going to ask the participant at a 90-day phone call if they'd like to participate in a survey. Should they have any questions, we definitely want to answer those questions for the patient at the bedside. And we want to give them the brochure, which is in that packet. And then our IRB has asked us to document that we are notifying the patient. So we want to document that that conversation happened, and that is one of the questions in the enrollment form. So next slide. So we are not expecting you to work 24 hours a day, 7 days a week. So as we were thinking through pragmatically how this could roll out in your site, we got feedback from clinicians that there will be times when someone's not going to be available, or the patient gets discharged before we can get over and hand them the packet of information and tell them about the research study. So the workaround for that is that we ask that you mail the patient brochure to the patient. So as soon as you determine that they are eligible, we just go ahead and send that information to them via mail. Next slide. So we do want to let you know, of course, as with any research study, patients can withdraw at any time. We do anticipate that it will be rare that when you approach a patient and let them know that the hospital is participating in the study and that we want to ask them to participate in 90 days, that they would ask to be withdrawn that very moment. But kind of thinking through all the possible scenarios, it could potentially happen. So if that is the case, you can go ahead and go to the next slide. We can withdraw them directly from that dashboard that Lori was showing you earlier. So these are the quick and easy steps to withdraw a patient. So you would log in as you usually would to the data application. You'd locate that patient on the dashboard. You'd select from the pull down, the drop down menu there, withdraw form. You complete the form. I think that's around 4, maybe 5 questions there, and then that would be the last step. So that would withdraw the patient from the study. If you at any time need to get some support with that, you have Sarah Jones, who's on the line, or myself, who are happy to help you with that process as well. Next slide. This is just a quick note for the Central IRB. Our continuing review is going to be coming up. We're going to get that submitted in mid-December, so we'll start working on that probably in late October. And just wanted to let you know that I will be working with you and doing that centrally here. And for those with local IRB approval, I will also be more than willing to support you on your continuing review as well. And if you go to the next slide, I just wanted to say thank you to the Wake Forest IRB, and certainly acknowledge the many people who spent hours working through this design as a pragmatic, randomized, cluster randomized design trial. Was a lot of innovation that went into the development of this particular study protocol. So we had some very helpful IRB team members who were a part of that. Okay, so next slide. So just wanted to tell you a little bit about our, this is also administrative topic, is reimbursement and invoicing for participating in the study. Always a fun topic. So as a control site, you will be performing the case ascertainment. For each patient that you case ascertain, and you fill out the eligibility form and the enrollment forms, you will be paid $50 per case. Once you are crossed over into the intervention, which will happen approximately a year from now, your site will also be eligible for the additional $105 for completion of the intervention activities. So for this phase of the study, just the $50, but a year from now it'll be $50 plus the additional $105. So next slide. Do want to let you know that we will be invoicing quarterly on a quarterly schedule there, and that we will be working with you to, you can go ahead and go to the next slide, generate the reports. So there's no need for you to track that. We have the data team. Anything that is entered into that data portal will be captured. The data team will help us with running the reports. We will send those reports to an administrator at your site to sign off on and verify that that looks accurate. If there's any discrepancies at that point, we would work through that. And then we will generate an RFP, so a check to come to your site. You can go to the next slide. Thanks. So you either get a check, or if the preference is for a direct deposit, we can coordinate that as well. And then just a quick reminder on that last bullet, that payment will be issued directly to your hospital that's listed on the letter of agreement. And then you can go to the next slide, and that's just an example of our invoice. And then the next slide is kind of the intro to our website. And this is the last slide that I have on, that I'm covering today for the administrative section. And we just wanted to let you know that we do have a study website, and a lot of helpful information is posted there. The URL is at the bottom there. This is just a screenshot of our homepage, but we encourage you to, in your free time, take a look there. If you have any suggestions for the website, something would be helpful to have posted there for you to make your job easier, we definitely want to hear about that and get that. We're always welcome to feedback with our websites. So that's it, and I'm happy to take any questions that you have either now or later. All right. right, well, thank you so much for your attention and your time. Please don't hesitate to reach out if you have a question in the future to our team members.
Hi there, this is Laurie, and I'm just going to pull up real quickly the agenda. It may take a minute. And as we can see down here, the last few minutes of our talk is going to be just a reminder. If you remember those first slide I spoke of with the arrows, here we are at the case ascertainment in preparation for enrollment, which will happen October 3rd. Excuse me, launch, which will happen October 3rd. And in order to make that happen and for you to have all of the information you need, again, I'll encourage you, for those of you who have not had time in your incredibly busy schedules, to please fill out the brochure, send in the logo, and send in the W-9 and new vendor form. That way you can be reimbursed and you can distribute the brochure to the patient and the blood pressure log. So all those are important. And also in a previous email you should have received a little graphic that showed who to contact for various things, and I hope you find that useful. If in doubt, always contact me. I really look forward to and I really enjoy talking to folks. That's really the highlight of my day, as much as I love data. And then I also look forward again to the site visits. We've started on our Wave 1 site visits, and I just wanted to say to you, I really encourage you to share your uncertainties and your questions, because it is a great opportunity for all of us to learn. In one of our Wave 1 sites, it was a new staff member in a new hospital that was also new to stroke, and that particular staff person is an excellent clinician, but she had a lot of questions, and I kept prodding her and saying, you know, give it to me, we want to know. And as a result of the fact that she looked at everything with really fresh eyes, we made some changes in our data forms that that she brought up. So please, I encourage you, don't hold back. Especially when we come to the site visits, we are there for a very brief time. We really try hard to not impose too much time, but at the same time we want to be really helpful. So those site visits, on average, they've only lasted an hour, and we've gleaned a lot of great information, and it's a wonderful opportunity to meet each of you in person. And then that is a great kickstart to working together and addressing all of these important issues. I know that each of you, from your clinical perspective, is really glad to have the opportunity to continue to work with patients who you've done such a great job treating all these stroke patients and TIA cases. So this post-acute phase of the scenario is critically important, and we are very glad that we are working with you on that. So we are also going to be doing bi-weekly calls, but again, at first they'll be, actually it should be bi-monthly. I was momentarily distracted by that. It should be bi-monthly calls. And so at first they'll be a couple times a month, but then when I realized everything is going smoothly, it doesn't seem like people have any big challenges, I will send out a few surveys. If all's going well, then there's no need to hold a call unless there's something that we all want to share. So after all of that, I really want to open up the floor to everyone and give you an opportunity if you have some questions right now. We have all of our team members here, and we again encourage you to share any questions or ideas you may have.
Hey, this is Davita with Blue Ridge. Can you hear me?
Yes, I can, Davita.
Okay, quick question. I was just going to send an email because I'm embarrassed to ask my question, but I'm just going to ask it.
Oh, go ahead. It's great.
I don't know that we participate in Get With the Guidelines. Is that something that we need to participate in order to be able to upload all this data? I don't know that I understand all that well.
No, my guess is that what you're doing is entering data into another software system for your CMS core measures. Is that correct?
I'm sure we are. I just honestly, quality does that, so I'm sure they know. I've just never heard anybody talk about Get With The Guidelines here, so
that's fine.
So whatever we're using will work.
I think we'll have to find, this is Sarah, we'll find out what it is that you're using and if your data goes to Get With The Guidelines, because we can download it from that source, but not other platforms.
Okay. Do
now,
you want me to find that out?
Say that again?
Do you want me to find out what we're using?
That would be helpful. I mean, I think that's something we can discuss at the site visit, but we can also work offline with you on that and investigate what you have. And I will say that by no means do you need to sign up for something, a service that you don't currently participate in if it turns out you don't upload data to Get With The Guidelines.
Okay.
Because you can just use the option that Laurie went through for the stroke care card, and that's already built into the system and easy to use and streamlined. So that would be what you would do in the alternative, and it won't cost you any money.
Well, and it may just be that CHS probably does some of this for us, and I just don't know it.
In some systems, that's what we've found in for all the years that we've been working together on the Stroke Care Collaborative. Many of the large systems will have one person that enters all the data for stroke, for example, and they will, if they're a large system, they often use Get With The Guideline, which is why we mention it.
Yeah.
And we will definitely work with you to find that information. And,
okay, I'll work
too. For you.
Thank you. I'll work too on finding that out, because now that I'm asking that question, I'm sure CHS probably does that for us, because we just we're going live with telestroke and teleneurology at the end of November, so I'm sure they already have all of that mapped out too.
Yes, and if you can talk to someone from your end about it, and I will float it up to other contacts we may have. Who would be your main administrative site for me to contact?
If you contact me and William Miner right now, one of his quality nurses is going to be the individuals that's going to maintain this data and this program and things like that for us.
Okay. What I would love for you to do, Devita, is to send me a quick email, and then we will figure this out pretty quick.
Okay, and who is speaking? I'm sorry.
Okay, I'm sorry. This is Laurie.
Laurie Meta.
Yes.
Absolutely. I'll send you an email right now.
Cool.
Thank you very much.
Sure thing. Anyone else have any questions that we can take care of?
Hi, this is Denise at Novant. We currently enter our patients into MedAI and then data share with Get With The Guidelines. So I have a couple questions. I'm not sure at what point in time that data share occurs, and if we would be able to meet the 4-week mark. The other question that I have is related to TIAs, because currently we do not patients into Get With Guidelines, nor do we enter them into MedAI. So will there be another system for us to be able to enter those patients?
So I think that the 4-week requirement is you know, it's in an ideal world, but we understand that some systems have different timing, and so that should work for us if we can find out more about how frequently the uploads are done, just so that we make sure that we get those data. and know when to access them. And then your other question was about TIAs. So you have two options, and I don't know who's doing the Get With the Guidelines where you are now. They can start entering TIAs, or you can use our platform for entering the data for TIAs on the stroke care card.
Okay, so we can use the stroke care card directly for entering TIAs?
We could arrange your account that way.
Okay, and I wanted to ask one other clarifying question. I believe I heard you say that you want to include ED discharge patients as well.
Yes.
Okay, thank you.
And can you repeat your name, please? This is Laurie.
Hi, Laurie. Denise Sorensen from Novant.
Denise, hi there.
Hi.
These are great questions. Anyone else have a few others? Okay, well, given the fact that I hear silence, I'm going to assume that you all need a few more minutes to percolate things and also make the assumption that you have incredibly busy days. So I will go ahead and end the call. Thank each of you tremendously for your valuable time, and I really look forward to participating with you on this COMPASS study. So have a great afternoon, and again, if you have any questions, just go ahead and email me and we will take care of it. Thanks again to each of you.
Thank you so much.
Thank you.
Thanks. Bye.